Yes, thank you. And that was a great talk. Happy to be here. And our focus is on ethics and human rights. It's very relevant to my concerns today. I'm the executive director of INCO, and that's a nonprofit organization. We have 35 member organizations all around the world. And our purpose is to support the rights of the 98 million adults worldwide who use safer nicotine in order to avoid toxic forms of tobacco. Coincidentally, I used to teach healthcare ethics at a historically Black university in the United States called Howard University. And we were teaching medical students and nursing students, and we focused on 5 basic moral principles. The first 2 are beneficence and non-maleficence. And so that's do good if you're a doctor or a nurse. And non-maleficence is do no harm. That's a common phrase in English. And then there's autonomy. So this is the third one. Autonomy is truth-telling. Autonomy is informed consent and informed choice. Very important. And then there's justice, which is treating everyone equally, whatever their gender, whatever their ethnic background. And so justice is important. And finally, utility. Now, utility comes from John Stuart Mill. It's the greatest good for the greatest number. What strikes me when I look at the tobacco control field now is it takes a population-based approach to interventions. So this is very much a utilitarian approach. And if you just open an introductory textbook for medical students on healthcare ethics, you will find it full of case studies that are about the conflict between autonomy, which is informed consent and truth-telling, and utility, the greatest good for the greatest number. And my general sense, and this is a very broad brush comment, is that tobacco control policies are often blind to the importance of autonomy. And here, as I'm strongly supporting what Lynn says, which is that smokers and users of safer nicotine and the general public need to be, and policymakers need to be informed. And the evidence shows and the surveys shows they're profoundly misinformed now, unfortunately, about nicotine and about the relative risks of different nicotine products. The main thing I want to focus on is something I've really been thinking a lot about now, especially because I've done surveys of advocates in my community, is the issue of mental health issues. But before I get there, to paint the bigger picture, let me just focus on the high-income countries where we have succeeded in getting smoking rates down to relatively low levels. The pattern of smoking in these high-income countries, especially like the United States or the United Kingdom, where smoking is now down to 14 or 15% of adults, is very, very different from the pattern you find in many other countries, low and middle income countries. Just to take one example, China, more than 50% of men smoke in China, 30% of doctors smoke, and there are smoking lounges in the hospitals for doctors and nurses still in China. So the pattern there is kind of like it was in Europe and the United States and the UK, 40 years ago, where it's the general population is smoking. Once you get down to 14, 15%, I'm going to argue that the people who are still smoking are by definition those least able or least willing to quit. And when we look at who those people are, we can just turn in the United States to CDC data. American adults living with mental health problems smoke 40% of all of the cigarettes in the country. And but it's not just people with mental health problems. So the smoking is concentrated now in our most vulnerable communities. Obviously, this raises social justice issues and rights issues. Those vulnerable communities are where the smoking rates are highest are low-income peoples or people in the LGBTQ community or the indigenous population or people who are homeless or people who are using illicit drugs. And then the big one, people living with adults living with mental health conditions. So to take and focus on that in the category which some people now call neurodiversity issues, adults living with ADHD or autism, 40% of them smoke. And the general population in the US is 14%. Adults living with bipolar disorder, it's 60% smoke. Adults living with schizophrenia, it's 71%. And so, and the numbers are very similar for people who use opioids or people who, so we need to understand that the pattern of the population that are using cigarettes or combustible tobacco is very, very concentrated now in these communities who are by definition vulnerable, already stigmatized, and then because they smoke, they're doubly stigmatized. And if they are to switch to a safer nicotine product, unfortunately, public health wants them to be stigmatized for that these days. And so that's my concern now, because I now have come to understand that a very substantial percentage of people in the advocacy community for safer nicotine are people living with neurodiversity issues. And so we have started to talk about this a great deal. This is your superpower, right? This is your ability to focus and concentrate. But the prevailing theory in the literature for these very high rates of smoking among people with many mental health problems is that they're self-medicating, right? So the impact of nicotine is not to intoxicate. It is just a mild increase in your focus, attention, and memory, and then paradoxically, a mild reduction in stress and anxiety, right? So if you're in any of these populations, you are under stress and you want to reduce your anxiety and stress. And if you are living with ADHD, you want to increase your focus and attention. None of this should surprise anyone, but nicotine is obviously so demonized that I would suggest that as with psilocybin and psychedelic therapy, decades of research have been neglected looking at the health benefits. Now, there are some studies using nicotine patches, transdermal nicotine, for adults living with depression, for example. They're quite positive. And so there is some missing research, but on the other hand, there's a lot of research. It's just scattered, and I would point out that the U.S. National Academies of Sciences, Engineering, and Medicine conducted a thorough analysis of the benefits and harms of cannabis and cannabinoids, and the report is published in 2017. It's quite stunning that there is no comparable review of all of the science on nicotine's dependence-forming characteristics, its health benefits, and its potential risks at the same time, because obviously, as Lynn points out, smoking is killing a lot of people every year. It's a more than COVID-19. So let me start to wind down and simply say that the fact that smoking in high-income countries is now concentrated in our most vulnerable communities, and they are being denied in many countries access to safer nicotine alternatives, raises tremendous human rights and social justice questions, at least. And it's an issue where we should be getting more healthcare ethicists, bioethicists, to start thinking about these things, because they approach these problems with a different set of tools, mental tools. So that's let me leave it at that, and I just look forward to further conversation.